Hi, I'm Cindy Francke, and this is Cranial Nerves, Identification, Anatomy, and Monitoring. Right now, I want everyone to pause and make sure you have a fairly good sized piece of paper, 8.5 by 11, and a pencil. This will be needed at the end of the lecture. So, our cranial nerves, there's 12 of them. 1, 2, and notice they're all in Roman numerals. That's how we write the cranial nerves. Memorize this. Memorize, 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 because you don't want to have to be thinking about what nerve to monitor when the surgeon says, I want to monitor cranial nerve 10 as well. Okay, so you want to make sure you know these. And there's mnemonics. Mnemonics, I don't do well with them. This is it's a personal thing. I just memorized them, but these are a couple of them. So, on old Olympus towering tops, a Finn and German viewed some hops. So that's probably the most commonly known one. There's, if you're a Harry Potter fan, there's on, they traveled and found Voldemort, guarding very ancient Horcruxes. This is the location of the cranial nerves on the brainstem. Again, you kind of have to know this so that when you're talking with the surgeon or a neurophysiologist or a neurologist or whoever, that when they said we need to monitor the deep cranial nerves, you know that they're not talking about the olfactory or optic or even trochlear. They're talking the vagus and the hypoglossal because these are deeper into the brainstem. This is a graphical location on the brainstem, and this is Clinical Neuroanatomy Made Ridiculously Simple by Dr. Stephen Goldberg. And so, if they're done in the pons, they're not operating pons, you're going to 5, 6, 7, 8, which we normally do. They get done in the medulla, deeper brainstem. You might get 5, 7, 8, but you got the 9, 10, 11, and 12. This is a great book. Clinical Neuroanatomy Made Ridiculously Simple. It is available on Amazon for $24.95. I've had to buy it 3 times because my copies keep growing legs and walking away. So I'll get into the cranial nerves. And we're not going to spend a lot of time on this just because it is so boring, but you need to know it. Cranial nerve 1 is the olfactory. Its function is smell, and we don't test it in monitoring, but clinically during a neuro exam, they may be asked to smell some peppermint or some coffee or some very strong odor but is a familiar odor. This is the pathway. You don't really need to know this too much, but again, it's nice to know. Cranial nerve 2 is your optic, so its sight. Its sole function is carrying afferent impulses. So see it, and it carries it back to the visual cortex. It's not really reliable for neuromonitoring. You can do visual acuity and visual fields and pupillary light reflex and visualize the fundus for clinical testing. And we would love to be able to monitor this, but we just don't get reliable results. Now, I know people have done it in highly specialized areas with very, very good anesthesia. And I know University of Pittsburgh does it, and they get some really nice results. The issue is with monitoring in the OR is you can lose the optic nerve, but it doesn't tell you, again, how you can see it. You can be preserved, and somebody can still wake up with visual deficits. It arises from the retina of the eye, and it pops. Now, you do need to know this. This comes up on exams. It passes through the optic canals and converge on the optic chiasm, and then they can do here, and they come back. So what you see in your left eye comes to your right portion of your visual cortex. Cranial nerve 3. So this is the first of them that we can monitor. It's the ocular motor. It moves the eyes, it constricts the pupils, it accommodates, and it raises the eyelids. Yeah. The muscles are the medial rectus, superior rectus, inferior rectus, and we can test this with EMG, triggered or free run EMG. And here it is right here. This one you can record with surface electrodes, especially if you come back to the medial rectus muscles. I know people will place the needle electrode, they'll move the eye and place it in there. I'm not about to do that. I haven't been trained. If my surgeon wouldn't do it and my neurologist wouldn't do it, I'm not about to do it. When I was at the University of Washington, we actually had the neuro-ophthalmology surgical fellow come down and place them when we needed them for 3 and 6. People do it. I'm not going to do it. If something happens and this litigates, you're going to be liable on there, and you're going to have to show how you were trained. The cranial nerve 3, the latency of the EMG is 2 to 3 milliseconds from stimulus. So record from the inferior rectus to the inner canthus, but you might pick up from cranial nerve 4, 6, and 7. If patient has a loss of the cranial nerve 3, they're going to be unable to open the eye. And in Dr. Goldberg's book, it has a really nice way to remember that. It's a pillar, so cranial nerve 3 holds the eye open. The eye will deviate outward and slightly downward. The pupil will be dilated, it'll be non-reactive, which means you shine a light in it, it doesn't open and close, and it loses the power accommodation, so you can't focus. So here's what happens. Cranial nerve 3, nobody loves you when you're down and out. So it's down and out. You can see the pupil is dilated. Cranial nerve 4, the trochlear, it moves the eyes, and it's proprioception. So the superior oblique muscle right up here is the muscle that moves it. Again, EMG testing, and the fibers emerge from the dorsal midbrain and enters the orbits via the superior orbital fissures, and it innervates the superior oblique muscle. So this is the muscle. So 3 is on the side, 4 is up top. The EMG is, again, between 2 and 3 milliseconds latency, so it's hard to tell because you can pick up activity from 3, 6, and 7. If you lose it, then the loss is unable to turn the eye downward and outward, and the head will tilt to the opposite shoulder to compensate for extortion. So here is, both the eyes are going down. Cranial nerve 5, trigeminal, it chews. So this has got sensory and motor. So it's a sensory for the head and neck, the sinuses, the meninges, and external surface of the tympanic membrane, branches 1 and 2. The muscles are temporalis and masseter, and again, EMG. So it has 3 divisions: ophthalmic, maxillary, and mandibular. The fibers run from the face of the pons via the superior orbital fissure, that's division 1, the foramen rotundum, which is division 2, and the foramen ovale, which is 3. So you can see how this runs all along from here. EMG, the latency is 5 milliseconds, so it's a little bit faster than 2 and 3. a little bit slower. The recording, temporalis, or the masseter muscle. Masseter is generally what's used. Temporalis is usually in the surgical field. So you have them chew, and you can feel that big masseter muscle, and that's generally, it's up, right into the surgical field. So it's hard to place for temporalis. So if a lesion or loss of trigeminal nerve is an absent corneal reflex, so if they take a little feather or a piece of cotton and wipe your cornea, there's no reflex. It's kind of like when you first learn to put in contact lenses, the corneal reflex is like, oh, don't do this to me. I don't want this in here. There'll be absent sensation in the sensory distribution, and you can cause weakness and wasting of the masseter. In the sensory, from the motor, from the mandibular branch, the mandible will deviate towards the parallel side when the mouth opens. So when they open their mouth, if they have a left-sided lesion, it's going to go towards the left. And then chronic unilateral lesions will present with unilateral temporalis atrophy. So here's a picture. Absent corneal reflex, no blink in response to vigorous poking. I don't know any docs that use their fingers. They usually use a Q-tip. The loss of masseter. You'll also have this scooped out appearance on the affected side. So you lose the tone in here. Cranial nerve 6, the abducens, it turns your eye laterally, goes out. The lateral rectus muscle, makes sense, right? And again, people will move the eye and poke a needle in there. I'm not about to do that. EMG testing, and the fibers leave the inferior pons and enter the orbit via the superior orbital fissure. So it comes out of the pons and goes right there. The latency is 6 to 8 milliseconds, so it's a little bit longer again. You record it from the lateral rectus inserted from the lateral canthus. And again, you may pick up activity from cranial nerve 3, 6, and that should have been 4. I'm sorry, that should be 3, 4, and 7. Make a note of that. That should be 3, 4, and 7, not 3, 6, and 7. The loss is paralysis of the lateral rectus. Neither eye will move past the midline when attempting to look toward the affected side. Okay, remember that. We're going to show a picture here. The eye will deviate downwards and diplopia. So you get double vision except when looking to the side opposite the lesion. So here's cranial nerve 5, 6. So it's that way. This is the injured side. This is the normal side. So going forward, this goes just a little bit towards the midline. They'll go look to the right, the left side, because this is the right eye, towards the left side, but they're trying to look left. The left won't move, the right will. Cranial nerve 7, facial. So this is the muscles of facial expression. Smile, bare your teeth, frown, all that type of stuff. It's parasympathetic to all the glands of the head except for the parotid. And it's sensory for the ear and tympanic membrane. And there's taste of the anterior 2/3 of the tongue. So this is a pretty big, this covers a large portion of the face. So you'll have frontalis, orbicularis oculi, orbicularis oris, and mentalis. So EMG, the fibers leave the pons, travel through the internal acoustic meatus, and emerge through the stygmoid-mastoid foramen to the lateral aspect of the face. And it's a mixed nerve with 5 major branches. So temporal, zygomatic, buccal, mandibular, and cervical. So you need to know this because you need to know what you're going to monitor. So the latency is a little bit longer. It's 7 to 9 milliseconds on triggered EMG. General recording, frontalis, orbicularis oculi, orbicularis oris, or mentalis. I always did at least 3 branches. So loss is paralysis of the facial muscles with or without loss of taste on the anterior 2/3 of the tongue. Unable to close the eye. So in Dr. Goldberg's book, cranial nerve 7 is a hook and it closes the eye. And if people have loss of it, they may have to have a gold weight put into the eyelid so that it'll help close it. There's flattening of the nasolabial folds, so one side of the face is going to look different. The affected side, it's going to be a little flatter there. And disturbance in the secretion of the lacrimal and salivary glands. So you're going to have maybe some drooling or maybe not being able to produce saliva. So here is loss of frontal wrinkling, kind of like what Botox does to us if we put it up here. Bell's phenomenon. Loss of the nasolabial fold. So again, Botox, but it's only going to be one side. And then the mouth deviates to the normal side. Cranial nerve 8. So this is got two versions. It's the vestibular cochlear, two functions, hearing and balance. There's no muscles. So this is the only one that is not monitored with EMG that we normally monitor, okay? Cranial nerve 2 is not monitored with EMG either, but that's not one that we're normally monitoring. Because it has two portions, it has a vestibular and a cochlear side. You can see how it comes up here, cochlear, vestibular. So the testing is brainstem auditory potentials. And the fibers arising from the hearing and equilibrium apparatus of the inner ear pass through the internal acoustic meatus and enter the brainstem at the pons medulla border. So this one goes this way. So because it has two sides, a lot of times people will have balance problems, vertigo, really, really bad, and they can't function. And so the surgeons will go in and do what we call a vestibular neurectomy. And what our surgeons would do was we have a cotton wick electrode that the surgeon would place one side on the, put it on one side of the nerve, and we would record auditory potentials. If we did not get a response, an N1 from that side, that was the vestibular side. And then he'd put it on the other side, and we should get a response, and that would be the cochlear. And he'd back and forth, up and down, mapping it out. And so we told him, okay, that side's the vestibular, that side's the cochlear, and he went, and what they do is they will cut the vestibular portion. The patient dizziness becomes even worse, but eventually it will resolve. And as soon as the surgeon cut, when we told him to, we lost all auditory potentials. Wave 1 to wave 5. And he's like, what? I cut the side you told me. The room was so quiet, you could hear a pin drop. All you heard was beep, 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 beep of the anesthesia machine. Well, for people that are used to doing BEPS in the OR, we do a lot of wave wishing on there, and we just, the 5 will get long and broad. And we kept recording, and I told my neurologist, I said, I think we've got something there on the 5. I think we've got a 5 there somewhere. It's trying. You really just know if you can do enough averages, you're going to get that 5 to pop out. And my neurologist told the surgeon, just hang on, George, just hang on. We might have something. And so I upped it from 1,000 reps to 2,000, and it was still kind of there. So I went to 4,000. And then I went to 8,000, and we were about to get some Papaveron, which is a vasovascular constrictor, and we've had good luck for that. And all of a sudden, that 5 started to grow back after about 10 minutes, and probably 15 minutes or so, we had all the waves back. 1 through 5, they were gorgeous. They were back to baseline. And the surgeon turns to me And he goes, I thank you. The patient thanks you. My insurance company thanks you. So that was a really very interesting case for us to do. But they can visualize what side should be what. But unless they actually test it, they're taking a chance. No EMG, brainstem auditory vocal potentials. Loss is hearing loss. They'll get tinnitus and balance problems. Glossal pharyngeal. So again, this has many functions. It's the taste and sensation of the posterior third of the tongue. Helps with salivation, swallowing. It monitors the carotid body and sinus and the internal surface of the tympanic membrane. So the muscles is the stylopharyngeus, the swallowing, and again, it's EMG. The fibers emerge from the medulla, leave the skull via the jugular foramen, and run to the throat. So this one's coming from the brainstem out. Now remember, some of these go lateral and out to the brainstem, and some are the brainstem out. The cranial nerve 9, the latency for triggered EMG is 5 to 7 milliseconds. The stylopharyngeus muscle. You can also do the soft palate between the uvula and the posterior tonsillar pillar after intubation. I'm going to let either the neurologist or the surgeon or the anesthesiologist place this if I'm going to do the soft palate. I do not want to get in there after the patient is intubated, because if I poke something, guess who is in trouble? When they stimulate cranial nerve 9, you can have a decrease in the blood pressure and the heart rate. And you can be recorded generally with cranial nerve 10. So we had one case where, So if you stimulate it, the anesthesiologist needs to be aware if the surgeon's going to stimulate 9 and or 10, because the patient's heart rate's going to drop, their blood pressure may drop, and the anesthesiologist is going to get very, very nervous. The loss is loss of taste of the posterior third of the tongue, and you can get an absent gag reflex on the side of the lesion. So that's not good. People have to relearn how to swallow and chew their food, because there's not a gag reflex. So here's the function. Sensory, it's the pharynx, it's the tonsils, it's the middle layer, the posterior of the tongue, and the carotid bodies. So here, detect increase in blood pressure in the sinus of the carotid. Afferent signal sent to the medulla to decrease arterial blood pressure and heart rate. So that's when, if the surgeon stimulates, that the brainstem is going to go, okay, slow down. Something's happening here. Motor is the tongue and the pharynx. The testing is EMG, 5 to 7 milliseconds. You can see again, 5 to 7 milliseconds. You got to really be careful on reporting. You have to make sure that you can know the difference between, cranial nerve 7 and cranial nerve 9. I talked about that. Oops, I went the wrong way somewhere with that. It leaves the skull through the jugular foramen, passes forward through the internal jugular vein and external carotid artery, deep to styloid process between the internal and external carotid arteries at posterior border of the stylopharyngeus, then lateral to it, reaches the pharynx by passing between middle and inferior constrictor, deep to the hypoglossus, where it breaks into terminal branches. So it comes up and it just branches all out. The loss is the loss of taste of the posterior third of the tongue. Absent gag reflex on the side of the lesion, we talked about that. You can have severe pain in nasopharynx, back of tongue, ear, throat, tonsil, and larynx. Cranial nerve 10, the vagus. So it supplies the parasympathetic fibers of all organs from the neck down to the second segment of the transverse colon. So no motor parasympathetic to the transverse colon. It's responsible for the heart rate, gastrointestinal peristalsis, and sweating. And sympathetic function via peripheral chemoreceptors, so sensory extensions of the peripheral nervous system into blood vessels where they detect changes in chemical concentrations. Probably the most interesting story I have on cranial nerve 2, actually. All of a sudden, I'm watching the EMG, and we're recording from cranial nerve 10, and they're not stimulating, and all of a sudden I'm getting this boink, 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 this response from cranial nerve 10. And I asked the surgeon, I said, "You're not stimulating anything, are you?" I knew he didn't have the stimulator. I was, "No." And I'm watching this thinking, what is this? And then as I'm watching it, and I could hear the anesthesia cart, and the heartbeat was just after I'd see the CMAP. So what it was we were so close that we were recording that electrical impulse that the cranial nerve 10 was sending to the heart to beat. So my uncle had to have a pacemaker. And my aunt's like, "But they said his heart's okay." Well, he kept passing out. So, of course, first of all, they think it's, cardiac. He keeps losing consciousness. And they did autonomic testing on him and came to find out it was not his heart, but cranial nerve 10, his vagus nerve. So it was forgetting to tell his heart to beat. So they ended up putting in a pacemaker so that when the cranial nerve 10 was not telling the heart to beat, it would shock him. And it took a long time to get my aunt to get that through their brain. She's like, "But it's his head, not his heart that's the problem." And I was going, "No, Aunt Sandy, that's true. His head is not telling his heart to beat." So these are the different muscles: the cracothyroid, levator veli palatine, just a whole bunch of them. So the testing again is EMG. So they can stimulate from 2 areas. If they stimulate at the neck, the response is 2 to 3 milliseconds. If they stimulate from the posterior fossa, then it's going to be about 4 to 6 milliseconds. The cracothyroid, external branch of superior laryngeal nerve, the RLN monitoring endotracheal tube, which makes this much easier. Everybody basically uses that now, and it's along with cranial nerve 9. So it's the only cranial nerve that extends beyond the head and neck. So it comes out of here. Everything else ends at the brainstem. This one goes all the way down to the colon, to the proximal portion of the colon. If you have cranial nerve 10 injury, you can have dysarthria without dysphagia or vice versa. So the voice may be hoarse but intelligible. So it's going to sound like this. There's no projection. And it gets worse as the day goes on. There's going to be a slight difficulty in swallowing solid food. So they have to really make sure that they chew well. Trouble with moving the tongue while speaking. Hearing loss may result from damage to the branch of the vagus nerve that innervates the concha of the ear. And here's the cardiovascular side effects: irregular heartbeat, which was what my uncle had, and arrhythmia. Cranial nerve 11, spinal accessory. It's got the function of the muscles. The sternocleidomastoid mastoid is the rotation of the head away from the contracting side, tilting of head towards the contracting side, inflection of the neck, and trapezius, which is the easiest elevation of the shoulder and draws the head back. So shrug the shoulders. That's where most people will monitor from because it's easy to get to. The sternocleidomastoid mastoid, it's right there in the neck, got lots of other anatomy there that you don't necessarily want to hit. So the trapezius is big. We can get it away from the surgical field. One thing you do want to make sure, though, is that you place it after the surgeons have taped down the shoulder, because many times they will tape down the shoulder and they tape right over your electrodes, so you can't get to them. And usually what I would do is I'd ask the surgeon where they were going to tape. I would put them in, and then I would be recording while they were taping down so I could tell if they were taping too much. So I'd make sure there was no neuromuscular blockers on, and then I'd have let them know, hey, that's a lot of tension on that shoulder, and so they might relax it a bit. The spinal portion continues. The musculus uvula shortens and broadens the uvula. I don't know if anybody's ever seen that. Helps close the nasopharynx during swallowing. That is a biggie. And the levito veli palatini. I always think that sounds like a spell out of the Harry Potter series. It's the elevator muscle of the soft palate. Helps prevent food from entering the nasopharynx. So the accessory portion arises from the medulla oblongata and functionally is part of the vagus nerve as well. Pharyngeal branch, spinal part. The spinal portion is the ventral horn between C1 and C5. Pharyngeal branch and the special visceral efferent innervation. Testing is EMG. Latency is 1.8 to 3 milliseconds, so that's pretty fast. Easiest, again, is the trapezius muscle. Cranial nerve 11, we're still on 11. I'm sorry. The pathway is formed from the cranial root emerging from the medulla and spinal root, arising from the superior region of the spinal cord. So it goes, the spinal root passes upward into the cranium via the foramen magnum, and it leaves the cranium via the jugular foramen. So it goes up through here. So here's the trapezius muscle. It comes here, it goes down this way, and goes this way. Now it branches off. The loss will be weakness or paralysis functions, and they'll be decreased or absence. Nuclear or infranuclear lesion associated with muscle atrophy and fasciculations. So it's a lower motor neuron issue. So here is symptoms of nerve damage: weakness, uneven shoulders, and winged scapula. I'm sorry if that doesn't show up very well. It shows up pretty good on mine. Last but not least, the cranial nerve 12, the hypoglossal. Its function is to move the tongue, and it's all tongue muscles except for the palatal-glossus. Testing is EMG. The latency is about 6 milliseconds, and the intraglossal muscles of lateral and anterior 1/3 of the tongue, and I would definitely monitor both sides. If you've got enough electrodes, you can put 2 on each side or just put 1 on each side, and you may not be able to localize, but you're going to be able to tell them, look, I got something coming from the tongue. Again, I would do this after induction, and I would have the anesthesiologist do it. So the pathway is the fibers arise from the medulla and exit the skull via the hypoglossal canal. So there it goes. It can cause atrophy and paralysis of the muscles of 1/2 of the tongue. And when the tongue is protruded, it deviates towards the parallel side. And while protruded movement toward the normal side is absent or weakly performed. So this is what it would look like. So the monitoring. So why do we monitor? Why do we monitor anything? It's to identify and assist in the preservation and integrity of these cranial nerve function during skull-based surgical procedures. But cranial nerve 10, we will also monitor during carotid endarterectomies, ACDFs, anything where The surgical site is at the neck. Here are the cases we monitor, and I'm not going to go through all of them, but this is a nice little thing. So you can see that some of these are neurosurgery cases, and some of them are strictly ENT cases. So mastoidectomy, tympanoplasty, trigeminal nerve, microvascular decompression is generally neurosurgeon. So you can see thyroidectomy. So all of these are, you're going to be working with neurosurgeons and or ENT surgeons. So how do we monitor? It's passive recording. EMG is EMG is EMG, no matter if it's coming from the cranial nerve or from a spinal nerve. We do direct stimulation for identification, because if you remember back looking, there's not a lot of room on the pons and the brainstem itself, and they're all kind of bunched up there, and number 5, 7, and 8 just kind of live right next door to each other. And sometimes when the anatomy is not correct, that there's a tumor or something they're changing, so they don't know which one is which. They have a pretty good idea, but they want to make sure. So they'll stimulate for identification, and they'll also stimulate for integrity, make sure it's still working right. So it's compound motor action potentials. Summation of potentials generated by a single muscle fiber, and they make up the motor unit. The amplitude is going to depend on the number of active fibers, the distance of recording electrodes, and the origin of the symbol, and also the intensity of the stimulation. Generally, when I've recorded direct, let's say facial nerve, we're at 0.2, 0.1, maybe 0.05 milliamps. They're right on the nerve, and those nerves are very close to the muscles that they're innervating. So it's not like a spinal nerve root recording. You might go 2 to 5 milliamps even on the spinal nerve root, and the electrodes are further away. The nerve root is further from the muscle, and our electrodes are further from the muscle. So everything is right here on these cranial nerve monitoring. The amplitudes are usually 100 to 2,000 microvolts. Depends upon how much and where they are. So here's a nice example of CMAP, compound motor action potential. A burst is most associated with direct manipulation or traction of the nerve. It rarely indicates neural insult, and the most frequent time you see it is when they gave too cold of irrigation. So they irrigate, and we get boom, boom, and we'll say, I'm getting bursts. Yeah, we just irrigated. And I always would talk to whoever was scrub, whether it was a scrub tech or the scrub nurse, and say, let's make sure the irrigation doesn't get too cold, because it's going to irritate the cranial nerves. Training EMG, like I said, again, EMG is EMG, and it's EMG. It doesn't matter where you're recording it from. So you can get repetitive asynchronous responses, which are caused by medial traction or pressure to the nerve. May occur for no apparent reason. And sustained trains may indicate some degree or neural insult. So we've all had the surgeon say, we're here this train to do, and you tell the surgeon, and they go, I'm nowhere near it. This really happens a lot in spine cases, but it can happen in these ENT and neurosurgery cases as well. All I can tell them is it's firing. I don't know what you've done. You can get trains and bursts at the same time. So you've got a train go do, and then you get a burst. So this one is irritated and this one's not happy. Amplifier settings. It's going to be the same as your normal EMG settings, except that you might need to make your input gain a little bit more sensitive, but you don't have to. So These are my settings, 100 to 3000 hertz. I leave the notch filter off. If you're using a machine such as the Cascade 16, if you turn the notch filter on, it eats up the DSP, and then you can't do anything else. EMG is fast, and so 100 hertz, yes, you're going to change the morphology of the wave, but we don't care. All we want to know is it there or isn't it there, and does it look the same at the end as it did at the beginning of the case. So for a clinical EMG, no, I'd never use these filter settings. For IOM, I do. We do the same thing in SSEPs. We use different filter settings for clinical as we do for routine. So your filter settings are going to be what you normally set for. Free run EMG, you're going to run it between 500 and 100 milliseconds, 1,000 milliseconds, which is 50 to 100 milliseconds per division because you have 10 divisions. Triggered, you want it a little bit slower so that you can see it. You want 20 to 100 milliseconds, which is 2 to 10 milliseconds per division. You're going to use constant current. The duration is going to be 100 to 200 microseconds, 0.1 to 0.2 milliseconds. Remember, if you're using 100 microseconds, you're going to use more current. 200 microseconds, you're going to use less current. Normally, I use 200 microsecond pulse width and went really not above 0.2 milliseconds. I'm 2 microseconds, 2.2 milliamps. Your rep rate is going to be 2 to 10 seconds. Maximum intensity is about 2 milliamps. And this is generally when they're recording through tumor. So they're trying to map it out. You might go a little bit higher. And so because of that, my surgeons like to hear the stem artifact so that they could hear that tick, 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 tick. So they knew that the circuit was being completed. If they didn't hear that, then they weren't sure if the circuit was being completed, and did we just not have it on? The CMAP threshold for direct nerve is between 0.1 and 0.5 milliamps. Indirect is 1 to 2 milliamps. And again, most of the time the surgeon will want the speaker on. They want to hear it. So there's a couple different types of stimulators. This is a monopolar. This is best for mapping and identifying the nerve. So is this cranial nerve 7? Is this 5? Is this 8? And then mapping it out. So this is a PRAS probe. It's a flush tip. And then this is an ENT tool called a cartouche. And the cartouche is actually a resector and that's electrified. So as they're resecting off of the nerve, it's giving a stimulus. So it's going tick, 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 and it'll give them a compound motor action potential if they get too close to it. So this is really good for when they're taking tumor off of a nerve. Generally, the surgeon will use a flush tip because the ball tip is just too large. Remember, they're working in an opening that's about the size of a quarter, even though it looks like that it's huge under the microscope. A bipolar is more specific than a monopolar. So if they've mapped out the nerve and they want to see where the damage is it distal, is it proximal? I don't know very many surgeons that use a bipolar for cranial nerve monitoring. The anesthesias, no muscle relaxants after intubation, except for cranial nerve 2 and 8. You need 4 out of 4 twitches or 3 out of 4. It's really hard to get just 3 out of 4. You usually have 0 out of 4, you have 4 out of 4. Otherwise, for the cranial nerve portion, there's no other anesthesia issues. So now we're going to show how to remember the 12 cranial nerves. So this is where you're going to pick up your piece of paper, pick up your pencil, and follow along. So you're going to make draw this. Then you're going to make 2 2s. So this is a 1. This is 2. 3. So it's the eyebrows. Remember, it lifts the eyebrows. And you see what's coming up here? Cranial nerve 4. 5. Starting to take shape. 6. 7. 8. Little dangling earrings. 9. The 10. A heart. 11. To make your shoulders. And then 12 for your tongue. So I did not design this. It's really cool, but I found it, and this is the artist's rendition of it. If yours looked anything like that, that's really exceptional, and I'm really surprised. Mine does not look like that, as you can tell, because this is my drawing. Now, I do have to admit that I drew this on the computer. I didn't draw it freehand. I drew it on the computer, so that's why it's kind of wonky. But you get the general idea. So, let me know if you have any questions, comments, but that is the end of cranial nerve monitoring. If we were doing this in person, there would be one more thing, and it would either be cranial nerve bingo or cranial nerve charades, but it's a little hard to do that virtual. So good luck, and we'll catch you on the next one.